Well, kia ora koutou katoa and welcome again to the Ministry of Health, Aotearoa. We're going to be giving you an update today on the Omicron outbreak response and specifically on our efforts to monitor for new variants of COVID-19 here in Aotearoa, New Zealand. So my name is Ian Town, I'm the Ministry's Chief Science Advisor, and I'm delighted today to be joined by two of our key senior colleagues, Kirsten Beynon, our Chief Testing Advisor on my right, and Fiona Callaghan, our Lead Science Advisor. It's great to be able to have those colleagues participate in today's discussion. So we're going to give an overview of our border and post-border variant surveillance and our approach to testing. Both of these are key components of our monitoring for new strains of COVID-19. And then we'll have a general discussion about our tracking of COVID-19 in general. I'll be happy to answer any questions. Now you'll be aware that our normal 1 p.m. statement has already been issued, and that has all of the details of our case numbers for today, so we won't be going over those. Also like to draw your attention to the slide, which I hope will be helpful as we talk through the surveillance approach, and you can see from that there are a number of components to the surveillance strategy which my colleagues will deal with in some detail during the course of their discussion with you. So if we think now about the international situation, obviously we're still seeing further waves of Omicron around the world, and New Zealand of course has been experiencing exactly the same thing, with additional subvariants being detected here over recent weeks. As we know, once we detect a variant here in New Zealand, it does take some time to gain an appreciation of the severity, the outcome for individual patients with each of these variants. So there is a small chance that in the future a more aggressive variant may be found in New Zealand, but in general we'll have seen that emergence overseas, and that's where our international intelligence plays an important part. Now, of course, as you know, we have previously been working to an elimination strategy, but in December last year that changed, and we're now working in the COVID-19 protection framework environment. We're currently in the orange setting, as you're aware, which is about protection and surveillance, and hence the emphasis today on our surveillance approach. Now, those settings within the protection framework are reviewed regularly by our public health and science colleagues, who take a look around for international and local evidence to assess how appropriate these settings are at any given time. Now, as I've said, the Director General has assessed the current orange setting as being appropriate for this stage of the outbreak, and we have a regular program of reviews. Previously, they were undertaken every fortnight, and at the moment they are undertaken monthly, with the next review being timetabled for next week in the middle of June. So although we have experienced quite a peak of cases earlier this year, case numbers remain relatively high. And these factors continue to inform our decision making and our levels of protection through those settings. Of course, with winter coming, and we're already seeing the impact of this, the additional impacts of colds and flu are likely to add to the workload experienced across our already busy health system. Overall, the work that we've done up till now with our public health measures, the protections and vaccination rates are continuing to provide good levels of protection and leave us well placed for the weeks and months ahead. So to introduce Kirsten Beynon, our Chief Testing Advisor, she has a wide range of laboratory experience over many years in the New Zealand health and disability setting. She's going to kick off with a discussion of our border and post-border variant surveillance approach, which is so fundamental to us detecting new variants here in New Zealand. And following that, Dr. Callaghan, an epidemiologist and biostatistician who brings a wealth of scientific evidence to our work, will cover such aspects as the science behind whole genome sequencing and other key management tools that we're using for tracking the prevalence of COVID-19 in our community. So firstly, over to you, Kirsten. Thank you.
Kia ora mai tātou. Thank you, Dr. Town. Prioritising the health of all New Zealanders and a commitment to a science and evidence-led response has been critical to our success to date. Whilst we have moved away from elimination and capturing every single case, It is important we continue to identify trends in COVID case numbers, both at a local and national level. In addition, we need to monitor with which variants are coming into Aotearoa and circulating in our communities and having the greatest effect on our health and on our health system. We do this using surveillance techniques, which is the collecting of scientific and factual information from a range of sources, including testing different populations. We survey travellers entering New Zealand, individuals and wastewaters in our communities, and those who are sickest in our hospitals, and we can triangulate this information to understand the collective burden of disease. The knowledge gained through surveillance informs our public health decision making, as well as helping with the management of individual cases. It enables us to track how COVID-19 is spreading in our communities and where to direct our public health response. The Omicron variants in particular continue to circulate in our community, and open borders will bring new variants. We therefore need to remain vigilant at our borders and within our communities. For variants of concern, our intelligence gathering and surveillance activity begins overseas, which has assisted decision making throughout the pandemic. We monitor daily overseas reports on changes in the virus and developments in science and public health thinking to ensure our approach to testing for COVID-19 and the identification of new variants meets the needs of our response. So how does some of this work in practice at our borders? I'll explain. As previously said, we use a variety of information gathering methods and testing tools to provide us with information from a range of settings, which collectively provide a better understanding of the prevalence of COVID-19 in our community and to understand which variants are circulating. We deliberately avoid relying on sampling a single group of people and one testing approach. Rather, we sample from a range of settings and people to give us the best possible picture for New Zealand. Many countries have stopped testing at their borders, and others, like Canada, have moved to randomised sampling of vaccinated travellers. In Aotearoa, we are maintaining a high level of testing at our borders. People crossing our border are tested twice, on day 01 and 5/6 after they arrive. While this is reliant on self-reporting, the numbers are encouraging. For example, of the 37,000 people who arrived in New Zealand in the week ending 5th of June, 75% completed and reported 2 rats. Of the people tested, approximately 2.3% were positive for COVID-19. Currently, about a third of these positive new arrivals are getting PCR for whole genome sequencing. This gives additional information on the variants and subvariants that are circulating over the border. It is important that when people arrive in New Zealand, they have rat tests and, if possible, positive, seek a PCR follow-up. This enables whole genome sequencing and early identification of new variants. The Ministry is implementing a technology solution that will support rapid follow-up of travellers who are rat positive to encourage them to get a PCR. We are currently contacting all rat travellers who have not had a PCR in person. We have seen an improved uptake as a result of this process. Overall, we will continue to use a high-trust approach, as this is currently the most feasible to managing over 30,000 people each week arriving into New Zealand. Currently, we are building on our whole genome sequencing capacity and capability within New Zealand, and I'd like to take the opportunity to acknowledge the continued hard work and thank the New Zealand COVID testing teams and ESR who collectively ensure whole genome sequencing information is readily available to support the public health response. COVID has certainly sped up science. The result has been the rapid announcement of treatments, knowledge, experience and understanding. Applying that knowledge, which has improved as time has gone on, has held New Zealand in good stead. I would like now to hand over to Dr. Callaghan.
Thank you, Kirsten. So as we've said before, and it remains true, our strategy for managing COVID-19 evolves and our methods adapt accordingly. So the overall goal of surveillance is to give us visibility about the different aspects of the pandemic. So as such, there are a number of components, as we can see, to a good surveillance strategy. Looking internationally to begin with, so globally our surveillance system is part of an international effort to track the impact and the spread of COVID-19, and we continue to communicate with our international colleagues and monitor data gathered from around the world. And then within Aotearoa, we need visibility at the border, in the community, and within our hospitals. And surveillance of each of these settings has different goals. So at the border, we need information primarily on new variants entering the country. In the community, the goal is to estimate the number of cases, and then to characterise which variants are the most common and estimate the growth rate of the variant, and then potentially to anticipate if that will trigger waves of cases. For hospitals, the goals are to know which patients have COVID-19, which patients are currently infectious, so that we can take appropriate action to protect those patients and to protect the people caring for them, and also to monitor new variants that may be responsible for more severe disease. So we have a variety of tools, including monitoring developments overseas. We have RATs and PCR tests on new arrivals. We have people in the community reporting their RAT results, wastewater trends, whole genome sequencing in the community, behavioural surveys, among other tools. And each of these have their own purpose, and they bring a different piece of the puzzle to build up an overall picture of the spread and the prevalence of COVID-19 and its variants. Whole genome sequencing in particular allows us to detect and monitor the COVID-19 variants at the border and in the community. And the goal for community whole genome sequencing is to gain an accurate picture of the variants that are circulating across the country. PCR samples from hospitalised patients undergo whole genome sequencing where possible, and the most clinically severe cases are prioritised for sequencing when required. Currently, the BA2 variant is responsible for over 95% of the reported community cases in New Zealand, with new variants such as BA4 and BA5 beginning to show early indications of increasing in prevalence. And as we can see from the graph, the BA1 variant was common until recently, and now BA2 is dominant. So simply put, sampling from across the country informs the proportion of circulating variants in New Zealand, and then prioritising hospitalised cases helps us to understand which variants may be causing more severe disease in New Zealand. Of course, we have other management tools. So rapid antigen tests and whole genome sequencing are just two testing tools that we use to monitor for the presence of COVID-19. For instance, regular wastewater testing across the country is another surveillance tool that we use to monitor the level of COVID-19 in our community, and also to monitor variants. Wastewater testing proved crucial early on in our response to COVID-19 as an additional precautionary measure, helping to rule out or identify any undetected COVID-19 infection and provide the respective public health advice. Now, with ongoing community transmission, wastewater is used to measure the levels of virus present in the wastewater, and therefore it allows us to monitor the level of infection in the community. And it also provides information on the overall trend, indicating whether an outbreak may be growing or declining. Quantification surveillance of wastewater is underway at over 100 sites from testing locations all over New Zealand, which indicates the level of COVID-19 in particular areas. And this information can also help us to monitor if there are any undetected levels of community transmission. Furthermore, there are over 20 Sentinel sites where variant testing is routinely conducted on the wastewater. And these samples are tested to detect whether a particular variant is present in the wastewater. And this gives us an indication of whether a new variant may be presently circulating in the community. Thank you. Back to you, Dr. Town.
Good. Well, thank you both very much for those excellent summaries. So just to wrap up then, obviously COVID is not going away. It's a continual challenge for us, as it is in many other countries. Our response has been continually adapting and responding to new evidence and new information to inform our response. As the virus continues to spread within New Zealand and globally, there remains a lot for us to learn. And in fact, the Ministry is currently conducting a request for proposals for research to help us learn from our past experience, but also to plan for the future. We have $9 million available, and that RFP closes in fact this Friday. We're looking forward to reviewing those applications, and we expect to make an announcement about the successful projects in August this year. Now, as I said earlier, winter is always busy for our health providers around New Zealand, and as mentioned, we're already seeing increased pressure on the whole of the health system. This may, of course, get worse as the impact of cold and flu starts to be felt across the system. And in addition, of course, there is always the risk of other diseases occurring, particularly, say, measles and whooping cough, which we haven't seen in recent times. Our immunity, our collective immunity to some of those infections may be a little lower than usual, particularly for flu, as we haven't had significant flu in the New Zealand area for 2 years now. Vaccination remains at the heart of our protective framework and is the best way for us to protect us and our whānau, including vulnerable population groups, for the worst effects of COVID-19. The more of us that are vaccinated, the greater protection we have, and this is no different for other illnesses. New Zealanders are well versed, of course, now in the basic public health measures, and these are really clear and are as applicable now as they were earlier. Firstly, to make sure that you are up to date with your vaccinations if you haven't had a chance to have a vaccination or a booster where appropriate, but also that the influenza vaccine is now widely available, and of course there's a continued program of catching up with the MMR vaccine for those for younger folk. Secondly, the mask wearing, we're all modelling that behaviour. I can see that in the room. So when we're indoors or we're with people we don't know, and particularly if ventilation is not good, it's still appropriate to wear a mask. They're effective in cutting down transmission of COVID-19. And most importantly, if you are unwell, it's important to stay at home and not go to work or school while you're unwell with a respiratory infection. If you are concerned about whether or not you've got COVID, obviously we have the wide availability of our rapid antigen tests, and we're delighted that people are continuing to upload the results of those tests, both positive and negative, which really helps us track case numbers around the motu. So thank you to those who are continuing to be diligent in uploading their test results. Doing those basics well has been a critically important backbone of our response to date. So thank you. We're very happy to take any questions you may have about our briefing or related matters. Thank you.
Could you please shed some light on, with our quite high wastewater test results, alongside a dropping daily case numbers, are we likely to still be in the peak of the pandemic with those variations?
Fiona, would you like to pick that one up?
Yes, I mean, I think when you compare the case numbers with the wastewater, you see more similarity than difference. So they both show that there was a peak and then there was kind of a levelling off, and the numbers have remained fairly steady. So I think they agree more than they disagree.
Even though it's still been quite high and steady since March, but case numbers have sort of fluctuated. What is the reason between that difference?
Well, there is always the possibility of under-ascertainment. So the number of rats that get reported, that's a lower bound for the total number of cases. So we know for sure that those are true cases, and then there'll be people that for whatever reason don't get tested or don't upload their rat result. And so that's why we try to triangulate with the wastewater data, which doesn't sort of doesn't rely on people's compliance with the testing, and it tends to have less ascertainment bias.
So in terms of that, does that mean that we still are in the peak of the pandemic with what the wastewater results are reflecting?
I don't think we're in the peak, because that peak was earlier in the year, of course, but what we're seeing is a steady plateau, I think is the best word for it, and that's backed up not only by the testing results that we're reporting, mainly rats, but also, as Fiona says, with the continued detections in wastewater.
What subvariant do we have any thoughts about what subvariant might become dominant, and what will that mean for people who have been dual vaccinated and also the health system?
Yeah, so that's a really good question. So as Fiona has mentioned, and on the graph earlier, we've obviously started with that BA1 variant, then the BA2 has been by far the most dominant through the early months of 2022. We have detected the BA4-5 variants, as you know, now in small numbers and small quantities. If that does have a significant advantage biologically, often because it may be more transmissible, for example, we'd probably expect those numbers to slowly creep up over the coming months, and that's kind of the pattern that we're seeing in the UK at the moment.
What are the chances of somebody who's been infected with one of the earlier BA variants becoming infected with one of the more recent ones, such as 4 or BA5?
Yeah, that's a really good question. I'm not sure we have a precise answer for that right now. Obviously, the natural infection and the vaccination are giving really good protection against severe disease. Just what the level of protection is against getting new infections, we're not that sure about at the moment, but we're tracking that evidence. It's quite difficult to be certain the answer to that type of question.
And which of the current variants appears to have the most severe effects on infected people?
Yeah, well, we're just learning more about 4-5 at the moment, aren't we? So we don't have enough experience here in New Zealand. And in fact, there isn't that much experience even worldwide. So often we see in the UK or Australia get a bit of a handle on what the levels of severity are. We've seen, of course, with Omicron that although there are still a lot of people being admitted to hospital, a number of people have a relatively mild illness, which is self-limiting.
There are some cases of sort of vaccinated people being infected maybe a second time. Is that sort of a potential reality going forward, that maybe every year you can expect to get COVID once or twice, even if you're fully vaccinated?
I think that it's still unknown at this point. So, New Zealand has caught up to the rest of the world, and we're learning these things pretty much at the same time as everybody else. But that's an area of active discussion, and it is quite possible that we may be seeing over a longer time period repeated infections, particularly if new variants emerge.
And just following those questions on reinfection, what's the official advice at the moment around reinfection? Just is it still the sort of 90 days likely not to get COVID, but with reinfection, does that change things?
I think we've been caught out by one of your eagle-eyed colleagues who pointed out that our advice on our website wasn't exactly as we'd hoped to have expressed it. So our current advice, just for the avoidance of doubt, is that anyone with symptoms of COVID within 90 days of an infection should really be talking to their health professional about whether or not they need another test, and then depending on the result of that test, what sort of actions they should take. So our virology colleagues feel that it is quite unlikely that there'll be a repeat infection within that time, but if it does occur, that's a really good opportunity to chat to your doctor about what to do.
Anecdotally, have you been hearing much about reinfection cases within that 90-day period?
I think the problem is we don't always know if it is a reinfection or not. Obviously, if the rapid antigen test is negative, it would tend to point to it not being the situation. But of course, the symptoms of a common cold or even the early stages of flu are very similar. So it's important really just to be staying at home, looking after yourself, keeping warm, and then if there is a deterioration, talking to your family doctor about what to do.
Just on the sort of health system pressures you're mentioning, so cases of flu in Australia are pretty high at the moment. Obviously that's something we're worried about here. Would we ever sort of consider giving free flu vaccinations to everyone in New Zealand, sort of just try and keep that pressure on?
Yes, we certainly have extended the eligibility for the free flu vaccination, bringing that age down and also making it available for those under 5. I am not sure of the exact reason, but I understand that there was a supply issue as well, so actually making it available more widely may not have been possible this year.
Is there any modelling at the moment which says the percentage of New Zealanders who have had COVID?
Yeah, that's a good question. Fiona, do you have any intel on that one?
I don't have the modelling data in front of me, given this was a surveillance briefing. But yes, they do monitor the number who have reported a result and who have been infected, and then also estimating in order to account for that under ascertainment. They try and give an estimate of who has been infected but perhaps not reported.
Do you know off the top of your head if that's more than half of New Zealanders?
I don't believe so at this point, but I'd have to check with
We can
the
get
data.
back to you on that, yeah, for sure. Yeah.
What are any updates you have on Dr. Bloomfield, who tested positive COVID while over in Switzerland?
Well, he seems to have made a remarkable recovery. I was talking to him just a few moments ago, and he's back in New Zealand and I gather feeling pretty well.
Have you seen reports from the Australian study which looked at liver damage post-COVID infection? I don't know if that's something, or that people were having I think it was liver or kidney issues. Sorry, I may have got that wrong, but has there been any studies in New Zealand about that post-COVID sickness?
No, it's a good question, and there is concern, I think, amongst the medical and scientific community that there may be long-standing damage to various organs, and some of the symptoms that people have experienced, aches and pains, brain fog, some of those other symptoms almost certainly represent some impacts on those organ systems. We don't have any New Zealand data on that at the moment.
We have been so to look at long COVID though, that's right, and that's what have we been finding from those sort of investigations?
We're just getting underway with that program of work. So in the science team, we've been looking at a lot of the evidence base around long COVID. We haven't done a systematic survey of how many people are experiencing symptoms of long COVID, which is sort of beyond that 3-month phase as yet. But we are developing guidelines, which we'll be working on over the next 6 weeks, and we hope to release those in July. We've assembled an expert advisory group, and Dr. Martin Chadwick, our head of allied health professions, is leading that work.
The CDC in the United States says people who are pregnant or who are recently pregnant are at increased risk of severe illness from COVID. In light of the discussions happening now around seeking boosters, should pregnant women or women who've recently been pregnant make inquiries about getting fourth doses or second boosters?
We have provided Cabinet some advice, and I think the Minister announced in general terms that we would be making a second booster available. Cabinet hasn't decided on the specific categories as yet, but in general our advice is to offer boosters to those who are more at risk of severe outcomes. We haven't given specific advice around pregnancy at this stage.
So the law currently being considered, the amendment to the Act currently under consideration, would not include pregnant women, it should include?
I think there are two separate processes. One is the enabling legislation, which removes the need for a doctor to actually prescribe the vaccine. That will be going through a select committee process, I understand, from the Minister's office over the next little while. So we'll be looking for further advice from various consumer groups and also MedSafe and other medical bodies about the right target for that.
Is there work underway to sort of improve vaccine rates for children, 5 to 11-year-olds? Which I think 90% of that.
Yeah, so it started with quite a surge, didn't it, in the early days, and then the rates have dropped off. I mean, this is an important decision for families and their whānau to take, so there's no mandates or requirements for children to be vaccinated. So it is effectively an informed consent process for the family. We've provided a lot of evidence. We believe the vaccine is safe and effective in that age group. At the end of the day, it's still a decision for families to take themselves.
Is the Ministry sort of worried at all that maybe the vaccination program's lost a bit of momentum maybe in some areas?
Well, we know from history that vaccination programs do lose momentum, so we have to keep up providing feedback to people about the level of coverage. We're working with our providers across the DHB sector. Our Māori and Pacific providers are still working exceptionally hard to close those gaps.
And one about monkeypox. How are we particularly worried, or how worried should we be about monkeypox?
Yeah, so monkeypox has been the subject of quite a bit of active discussion amongst our science team, as you can imagine, and our public health colleagues. So we're following those international developments really closely. As you probably know, one of the larger outbreaks has occurred in Britain, and there are about 300 cases so far. So we are aware that the cases have been detected in Australia, and you may recall that Cabinet yesterday decided to make it a notifiable disease. So if we do detect cases here, we think our normal case identification, contact tracing and isolation will be the best first approach to stop it spreading more rapidly.
Is there sort of enough capacity in the system to cope with that?
Well, if the number of cases stay relatively low as they have in Australia and the UK, absolutely, yeah. Good, are there any more questions before we finish? If not, thank you again for coming. It's always a pleasure to see you up here at the Ministry of Health. Thanks again.